Delighted to be here. Thanks, Andy, for setting this up. My name is Brian, and this is Keith.
Cheers.
And I operate Physio Effect out in Surrey, and then together we operate Resilient Physiotherapy out in Vancouver. And today what we're going to be presenting is obviously shoulder. Trying to help reframe the shoulder. We're not trying to reinvent anything or reinvent the wheel. We're just trying to see if we can add either new things or change the way we see the shoulder to help what you guys do currently with shoulder patients. Okay.
Yeah, also like some of the stuff that we go over today, it can be pretty simple. You guys might obviously already have gone over it. So if you have, just bear with us and just try to use the time to consolidate a little bit of the information. We're not going to be going over like exercises or anything like that. It's just it's a little bit of a different, more focusing on like psychosocial factors and all that kind of stuff. Like all the other things of a treatment and assessment that you need to talk to with the patients and go over with the patients as well, that some people will just kind of miss and neglect. So, yeah, cool. Just give us 1 second.
So learning outcomes for today, we're going to try to just understand the relationship between psychosocial factors and the experience of rotator cuff related shoulder pain. We're going to try to understand a little better the issues related to shoulder pain rehab, things in and around treatment and rehabilitation, explain time frames for shoulder rehab, understand what to look for in an assessment to help with prescribing and progressing exercises. We'll do the next slide. So what is rotator cuff related shoulder pain? Essentially what it sounds like. It's pain in the shoulder. It's related to the rotator cuff muscles. And this is a term that I like to use in clinic, just because I want to move away from terms such as rotator cuff tendinopathy, tendinitis, partial full thickness rotator cuff tears, bursitis, subacromial impingement, all those syndromes in general, right? Because what we know through research-backed evidence is that surgery versus conventional or conservative treatment involving exercises, I think the outcome is going to be the same, especially 10-year follow-ups, function-wise, same thing. So the idea here is to understand that there's an incentive for patients when we educate them to show that there's a less invasive intervention to give them. We can suggest exercises, and what do patients know? Rotator cuff muscles require strengthening, and that's where we come in. That's our bread and butter. We try to strengthen them in that way to help them get over the pain that they have. Shoulder, number 3 MSK complaint, high enough for me to realize that even though we learn about the shoulder over and over again, I think it's always good to consolidate and refine our shoulder rehab. So whether we're continuing to relearn the anatomy or just going to courses and learn about someone's perspective on pain and how they rehab, then I think that's more of a motivation for me to at least continue to learn about the shoulder. Because I think 70% of patients will come in and they'll have shoulder pain. And I believe within a year, 50% will come back and it'll recur. So that's just another motivation factor to kind of get better and better at rehabbing shoulder. So causes of pain. So we can probably talk about pain itself over like 3-4 lectures, but we're not going to do that today. But one of the things I think about when it comes to pain is a quote by Greg Lehman, a renowned physiotherapist, who said that pain is the opinion of the brain. By definition, it's a distressing event related to either potential tissue or non-tissue damage, and there's some sort of component related to emotional, behavioral, social, psychosocial factors that we want to think about. Essentially what I'm trying to get at is that pain is more than nociception, it's more than tissue that we're talking about. It's related to the brain as well. So we're trying to shift away from what muscles involved, what joints involved. We're trying to get you shifting from not only that, but also thinking about what are the psychosocial factors involved. And we want to get into kind of finding out what their fears are, if there's any beliefs about what they think about their shoulder, and if there's any, I think more just what their views are on pain, and we're trying to change that or tap into that. And I think connecting with them that way will kind of get them to buy in a little more too. but essentially causes a pain. It's pathoanatomical, so soft tissue, neurophysiological, which just means there's hyperalgesia in the area, so you're a little more sensitive in the central nervous system, mechanical loading, and your immune system as well. But the big one we want to touch on is psychological stuff. Next slide.
We're good.
Sorry, it's a bit laggy.
No, all good. And this is one of the clinical models I like to use in clinic. It just helps me understand the patient a little better, helps me understand the presentation the patient is coming in with, helps me understand different presentations regarding the shoulder, all while still connecting with the kinetic chain, the rest of the body, biomechanical factors, and lifestyle factors. But obviously, psychosocial factors is the big one. But once we figure out which area of the shoulder we're dealing with, we also want to be mindful that we want to rule out red flags. We want to think about, is it coming from the neck? Is it coming from the mid-back or potentially somewhere else? But a great model that I like to use in clinic just to get the holistic view of the patient.
Yeah, so like Brian was saying, a lot of the stuff that we want to focus on is the psychosocial perspective, psychosocial factors primarily. The biggest one being pain beliefs. So pain beliefs is huge in this area as clinicians treating a lot of patients. Depending on where you are, do you guys see a lot of ICBC patients? Yeah, so a lot of ICBC patients will fall under a lot of this kind of category. You guys might be lucky and might see some good ones, but a lot of the ones I see have pretty much all of this all the time. So it's like pain beliefs, you got kinesiophobia, which is obviously the fear of moving, fear avoidance, catastrophizing, lack of self-efficacy, and we want to talk about their expectations as well. So the reason why we want to kind of go over the psychosocial factors a little bit more is because there's a lot of research out there that shows that a lot of the physical factors really don't make a huge difference in their clinical outcomes. So a lot of asymptomatic people will have structural issues that you may see in people who have a lot of pain. So like muscle length, muscle tension issues, the biomechanics or like scapular winging is often seen in a lot of different people that don't have any pain at all and they're fine day to day. The only really big structural factor that actually makes a large role to predict clinical outcome is progressions of rotator cuff tears. Now, obviously, they'll need a scan for that, and the ultrasound. There's obviously a cumbersome kind of wait list for that, but that's through a lot of research, we found that the only structural thing that makes a big difference is if there's a progression of the rotator cuff greater than 1 centimeter. Now, that's pretty much the only thing, but all these psychosocial factors we mentioned here, they play a much larger role in predicting clinical outcome. So we want to just kind of touch upon that a little bit and make sure that when patients come in and you do a good history take and you pinpoint these factors that people exhibit. So if someone says, oh, my doctor came in and told me I have a rotator cuff tear, I'm afraid to move and that kind of stuff. These are the things that you should be honing in a lot more early on in the treatment. Obviously, you'll be doing exercises and stuff, but we find that educating on these psychosocial factors makes a big difference. And if you can do that within the first couple of sessions and make sure that they buy into it and they start to move a little bit, they're comfortable with moving, or at least they want to try, that will set you up way better in the long term and overall in the treatment than just kind of addressing their structural issues or just doing exercises and that kind of stuff. So that takes us into the last part here, which is expectations. So with expectations, I like to set expectations early on. A lot of the times people come in and they'll ask you, of course, like, how long is this going to take? How long is this going to take? When can I go back to sport? Or they'll come in and be like, am I going to be like this forever, right? So when someone comes in like that, the very first session, I'll tell them, look, this can take like 2 weeks. You may be getting a lot better, but for the vast majority of people, especially with shoulder pain, it's not uncommon that you'll see them for 3, 6, 7 months, and a lot of people don't expect that. They had a fall, they hurt the shoulder, and they're like, oh, I should be back to go. I should be good to go in a couple of weeks. But that's generally not the case for a lot of people. If the person comes in with not a lot of these factors, then you can say, okay, well, maybe it can be a little bit quicker for you, but you need to understand these are the reasons why. And some of the reasons will be these factors here.
So this is an image that was created by another physiotherapist, Greg Lehman, and it just helps me understand, I'm sure you guys have seen it hopefully, yeah, but it just helps me understand pain and injury a little better, helps me, or helps patients that I need to simplify shoulder pain. But it's just a great way to view pain when it comes to shoulder specifically. Some people might see there's a lot of flaws to this, but for me, it helps people see the bigger picture when it comes to treatment. And essentially what it means is that usually when there is pain, it's going to be loads or certain factors such as this that exceed the space inside our cup. And when this cup is overflowing, that's why we have pain. And I like using this analogy with patients just because it's an actionable analogy. So you can do two things if someone has pain. You can either reduce the stressors in your life, right? So pointing out which ones of these are related to the patient, and we can try to see if we can minimize it. Or two, we can create a bigger cup. But essentially seeing these stressors just tells me that the patient isn't positively adapting to these stressors in their life, which goes to show that pain is much more than how much we can lift and bend. Pain is much more than a degenerative change that you see on the scan. It's more than what we put our body through day in, day out, right? It's related to things that Keith just talked about, the psychosocial factors, so the anxiety, the potential depression, the catastrophization, the fear. But I also think about, most importantly, like sleep, what their history is like, what their family history is like. Are they worried? Are they stressed? And what's their finance situation like? So to me, I like to ask these questions in the subjective. It might take a little longer than usual, but if I take that extra 2 minutes, I can really start seeing the bigger picture and helping the patient. But I think that's where the detail lies in treating patients, is just listening to them. But yeah, I think inherently these issues or these factors aren't terribly, like, they're not considered bad to me. These are all stressors that really bring out a response in us, and how we deal with it is dictating how we're going to deal with the pain. And if we can kind of reframe that for the patient, then we can potentially build a little more tolerance and a little more resilience for the patient going forward with rehab. So hypothesis, clinical diagnosis. So there's tons of diagnoses for the shoulder. It can get pretty confusing, and then a lot of them, or some of them, can be very difficult to diagnose or give a diagnosis right away. Personally, for me, sometimes I don't even give a diagnosis until the third, fourth session. Just because how difficult it is. And to me, that's okay, because a hypothesis, like clinical diagnosis, it's a work in progress. These things take time. We'll never know within the first session unless we have a scan that proves it, right? So for me, anyone that comes in with non-traumatic shoulder pain, we want to work towards a clinical diagnosis, but if we don't, it's not a big deal. I think what's more important is understanding what the patient's coming in with, what they're talking about, and seeing how they respond to treatment and seeing how they respond to rehab will tell me a lot more than you have bicep tendinopathy, right? Because how they respond during the exercise, how they respond 24 hours after, is more of an indication of what's going on. So just food for thought. How do we know if it's rotator cuff related shoulder pain? It's a diagnosis that we can't really see on a scan, but there's things that we can do to rule in, rule out if it's related to rotator cuff related shoulder pain. The analogy I like to use is Achilles tendon problems. And what precedes Achilles, obviously, is Achilles pain is usually a change in load. If there's a change in load in terms of their last week compared to the last 4 to 12 weeks, if there's some sort of spike, then you can start querying, like, maybe it is rotator cuff related shoulder pain. That in combination with, is there any reduced range of motion in external rotation, flexion, abduction? Is there any weakness in those movements as well? And then I started thinking it's probably going to be rotator cuff related shoulder pain. So those are things to think about, but obviously we still want to be ruling out red flags, C-spine, T-spine. But essentially these presentations are caused by unaccustomed, excessive, rapid changes or increases in load.
Yeah, so like Brian was saying earlier, there's a lot of clinical diagnoses that are very jargon heavy. There's a lot of different things that you can tell people, but in our practice, what we try to do is we try to simplify things. So this is not from us, obviously. It's from another physiotherapist, Adam Meekins, out in Australia. I'm sure you guys have heard of him. He basically categorizes most of his shoulders into these three categories. Now, when we learned about that, that's something we started to use as well, because what we found was that using these simplistic terms, it's a lot easier for our patients to handle, right? You can tell them they have calcific tendinopathy, they have all these other, huge words, which the doctor might actually tell them too, or another health professional. But what we like to do is we like to tell them, okay, well, this is what the doctor says, but really it just falls under one of these categories. So most of the time they come in, there's some sort of pain, right? So painful plus weak shoulder, painful and unstable shoulder, or a painful and stiff shoulder. Now, it's obviously very, very simplistic, but what we do is we tell them that this is what they probably fall under, and then we'll explain it to them. We'll tell them, if they have, like Brian said, if they have rotator cuff related pain, and it's because of an increase in load, or they did something that's non-traumatic, that will likely fall under the painful and weak shoulder, and then we'll explain to them why. And then by doing that, they can be like, okay, now I know what I really have and what I need to do to work on it. What we try to get across is that the specific diagnosis, sometimes it does, but not most of the time, it doesn't really matter too much. And for them too, because they don't really get much explanation from their medical professional, this is an easier way for them to understand what's going on. And if they need to tell somebody about it, it's like, look, this is what my physio said, this is what we're going to do about it, and on the backing of an actual diagnosis if they were given one. So this way it just kind of allows people to understand what's going on with themselves a little bit more, so that when they go and do their exercises, they understand why they're doing it. Because if you tell them, okay, do this exercise for a tendinopathy, they don't make that connection a lot of the time. But if it's because, oh, my shoulder's weak and I have a lot of pain and I need to calm it down and then do some exercises to build up the strength and build up the stability, then it makes a bit more of a difference for them, right?
This is language that I like to use as well when I'm treating patients. And unless they want the specific diagnosis and they want the full education, then great, go into it. But typically we break it down, and if the shoulder is weak, we ideally want to strengthen it. If it's unstable, we want to stabilize it. If it's stiff, we want to loosen it up. And it just feels like it's more tangible for the patient to understand what's going on in the shoulder, especially if they don't want to know or get the full details on what's going on in the shoulder. But yeah, language that I like to use in the clinic just to help bring things down.
And so the next slide, what we're going to talk about is a little bit of a quick assessment. Obviously, most of you guys here are kinesiologists, so the scope of practice is a little bit different. I'm assuming it's like less hands-on assessment kind of stuff. So I broke it down into a couple of categories that I like to do initially, and a lot of it is not hands-on. The first thing is checking range of motion. Very simple. I look at active range of motion. You're looking at mainly flexion, abduction, extension, external rotation, internal rotation. You can also look at external rotation and internal rotation in a little bit of a different angle as well. And then as needed, horizontal AB and adduction. So those are the main ones that I'm looking for. And when I'm looking for them, I'm looking for, obviously, does it hurt? And when does it hurt, right? Is it down here that starts to hurt right away? Or is it up here, different angles? So that's knowing just that and where it hurts can kind of direct your treatment, can direct your exercise and assessment further. If someone has an active range of motion issue and it's like quite early on, I'll also check passive range of motion as well. Doing passive range of motion can tell you if it's like a joint issue or if it's mainly soft tissue. Obviously, if you are able to get more range of motion passively and it's less painful, less sensitive for them, then it can be more of a soft tissue issue. If it's roughly the same, it can be mainly a joint issue, or just their system is so sensitive that that's something in itself that you're going to have to address as well. Instead of just kind of starting doing a lot of hands-on stuff and a lot of exercise, you might need to slow things down a little bit more. After doing the range of motion, I like to check out their strength. So just very simple isometric testing. I usually do the same movements, so flexion, abduction, external rotation, and internal rotation. Those are the main ones that I focus on. And again, with that, I'm looking at just generally, does it hurt right away when you activate, or is it after a certain amount of time, or if I'm trying to go as hard as I can, then it starts to hurt. And again, in different ranges. I find that with strength testing, different ranges is key. Sometimes when when you do it down here, it's fine. You know, it doesn't hurt too much, but if you go up here, then you're like, oh, fuck, that actually kind of hurts a little bit more, right? So that's kind of, again, something that can drive your treatment and drive your exercise prescription. And then something that I like to do as well, or I take bits and pieces out of, is the shoulder symptom modification procedure. Now this is an older kind of model, but I kind of like it still because it kind of helps me do some structural things and do some hands-on things to see if I can change their level of pain. I'm not going to go through the whole model, but one of the things that I like to do every time is I like to get them to activate certain muscles or the muscle group a little bit more, and then do the range of motion again. So for an example, if they do flexion and it still hurts, it hurts for them to do flexion, I'll give them a towel or like a pillow or something, and I'll get them to activate their external rotators. They'll activate their external rotators and then they'll do flexion again, and sometimes we'll have a much less level of pain. It might still hurt, but it's just less sensitive and they're able to go a little bit higher. That just tells me that by activating their rotators, they can get more movement, so that's what we need to focus on a little bit more. Other parts of the procedure is, you know, changing their thoracic position so they're always rounded. One thing you can do is you can try to get them to decrease their kyphosis a little bit and then go into the range. Sometimes that helps a little bit as well. And then there are other things for the joint, but that requires a little bit more hands-on stuff, so we left that aside. And then the last thing I do, or I don't do, is special testing. So a lot of the times, at least in physio school, you learn a lot about special tests and a bunch of different tests that you can do to target specific muscles. But what we learned is special testing for the shoulder isn't really specific, and it's not really that sensitive either. So for the most part, sometimes I'll leave it out. If I have the time and I want to try to see if specific ones hurt, then I'll do it. But knowing that it's not very specific at all. So I just kind of keep my assessment very, very simple. And again, it just kind of, it just goes to show you don't need a lot and a very, very in-depth, like a lot of special testing to really help a patient and help them with their exercises.
Management of athletes versus non-athletes. So when it comes to patients and management, I think about what are the things that we need to consider. And sometimes I wonder and ask the question, is there really a difference between the management of athletes versus non-athletes? And I would argue no. The only difference, again, in my opinion, is that we take athletes to a much higher level of rehabilitation. So the specificity that's required to get them back to doing what they need to do, the chaos in the environment that we're putting them in to get them back to doing what they're doing, is going to be totally different than someone who needs to mow the lawn. But at the end of the day, there's really not much difference. Really, the principles stay the same, especially for someone that comes in with non-traumatic shoulder pain. So something to think about. This is the part of the presentation that I like to kind of start considering what are the potential maybe issues in and around shoulder rehabilitation and treatment. What are the things that we can do to kind of help, again, reframe how we see the shoulder and add maybe potentially one or two things to currently what you do in practice. So issue number one I like to talk about is soft skills. I'm sure we talked about it. We've been taught this stuff over and over again, but it's still around for a reason. And certain things that I like to think about is obviously empathy and understanding. Are we giving patients the time and space to kind of talk about their issue and find out if there's more than just pain coming from the shoulder? Is there the proper education and advice that we give patients so when they leave their treatment the first time, do they feel kind of empowered or feel confident in handling their pain based on the timeline that you're giving them? And are we giving enough support and therapeutic alliance, or building a therapeutic alliance during treatment? And these are all things that I wonder, are we doing enough, and are we doing it at all? Tell me your story is something I think about. There was a study that showed that patients that come in and are allowed to speak for a couple minutes, therapists typically interrupt around 22 seconds. And I feel like just that obstacle just prevents them from getting out everything they need, which means we leave a lot on the table in terms of the patient's perspective on what we could really help them with. This is a quote that I think about when I'm practicing, especially early on, is that the most important difference between a good and indifferent clinician will lie in the amount of attention paid to the story of the patient. So I believe that if we give time and space just to listen, they share enough information, and that's just going to help explain their story, and you can build a better treatment plan around that.
And to go with the soft skills a little bit more, I think one of the most important soft skills that we need to work on is communication. So communications is very, very important. And one of the reasons why is that, at least for myself personally, when a patient comes in and sees me, whether or not I'm the first line of defense for them, they've seen other professionals before, they've seen doctors and that kind of stuff, or they'll come in with a scan. And I ask them right away, I'm like, okay, this is what you come in with, and this is what they've told you, but has anyone ever actually explained to you, take the time to explain to you what's actually going on? And I swear to God, 9 out of 10 times, the answer is no, right? So with the scan, the doctor will give them a scan, this is what you have, okay, now this is it, right? It's painful, go see somebody for it. And a lot of times they don't, either they stop there and they don't get that explanation of what's going on, or they'll seek other professionals that will try to help them. And again, for whatever reason, they don't get that explanation. So that's very, very important for them, because when they have the scan or they have their diagnosis from a medical professional that's not one of us, or a physio or a kinesiologist, that there's a level of fear that comes with the diagnosis, right? So let's say the doctor tells them, okay, there's a full thickness rotator cuff tear, which is a lot of scary words, right? That fear, it can be used as a great motivator for their rehab and to get them better. But a lot of times with that lack of communication and lack of explanation, then it's a lot more detrimental for them, right? So you need to explain to them what's going on, but in a way that they can understand. And then another thing that I touched on earlier was setting those realistic expectations. I said it right from the beginning, and it might take you a couple of times to actually set it in with them, right? Sometimes they don't believe you, or they forget even. So every session you have to keep reminding them, especially if it keeps coming up, you got to keep talking to them and tell them, look, we're going according to plan here, this is what we're doing. We need to make sure that you are actually following with the exercise program, and you're not overdoing it, and you're being realistic about what's going on. You can't fix these problems, and you can't get better overnight, right? So that's really, really important there. We like to use simple terminology that we already talked about, rotator cuff related pain, and that's just to keep things simple, right? A lot of the times we know that the rotator cuff is involved, and these other specific terminology is just too specific, and it can be more fearful than anything, more fear-mongering. The other one there is SAPS, which is just subacromial pain syndrome. So a lot of people like to use impingement. Again, we find that impingement is a very scary word, right? So what I like to do instead is I like to say, okay, the pain's around this area, which is just a acromial area, and I just say subacromial pain. That's what's going on, and we're gonna try to help fix that up a little bit. And then the last thing there is just kind of validating without fear-mongering. Now that's quite difficult as well. When you explain these things, whether it's what they are dealing with, what kind of exercise you're going through, what they're feeling, explaining their beliefs. So if someone comes in and tells you, oh, I'm scared of doing this, I'm scared of doing that, I'm scared that I'm not going to get better even. When you talk to them, you need to be able to validate those fears. Their beliefs are very, very valid, right? It's not just in their brain, not just in their mind. You want to make sure that they understand that it's valid for the way they're feeling. And when you shift them away from the fear and you try to get them to move more, we want to do it in a way that's not kind of belittling. A lot of the times, some clinicians, when they explain certain things, obviously you know a lot and you're trying to explain that to the patient, but maybe the way that they're explaining it, or they're using too much scientific words, and it just makes them feel very small, very little. Maybe you're just trying to talk at them, right? So it's very important to try to validate them without actually making them feel worse.
Issue number 2, we can't fix you. I believe this is the part where we have to carefully chat with the patient, and I think this is where our soft skills shine the most. And let them know that we can't fix them. I personally don't think we have the capacity to fix them, especially in the first but letting them know that we can't fix them is just a way for me to show I have other things I can provide. I can show you a lot of guidance. I can support you through this process and help you change little things or implement a lifestyle that can change these symptoms. But to let them know, or for them to perceive that pain can be fixed in one treatment, I just feel like it's unrealistic. And this is through no fault of the patient, because these are things we've set out as expectations for the patient. Typically, physiotherapists will give the massage or give the elbow in the back or upper trap, and they feel like they can leave feeling a lot better. And for me, obviously, I'd be wrong if I denied that service, but where can I do a little more? What can they take home? What can be more valuable to them than just a massage? And I believe educating properly and letting them know that, great, we've changed some symptoms, you might feel a little better, but here are things that can actually sustain symptom modification. And it could be a stretching that you're letting them know, but not just the stretch, but how can we incorporate it into your routine? I think about like brushing your teeth, like once or twice a day, hopefully. And you'll notice there's going to be improvements. Same thing with symptoms for pain in the shoulder. If you do your stretch in the morning, at night, or sometimes twice a day at least, for a minute or two, you'll start changing the symptoms that actually come about in the shoulder. And we do that for a long period of time, and you're going to start to notice that things start to change as well. So. This is just an article that just says reframing how we care for people with non-traumatic MSK pain. And I see that we're hopefully moving in this direction, and that's just through the education and, more importantly, the language we use with patients when we're treating them. Issue number 3, timeframes. I think this is kind of important, but these are things to consider when managing athletes and non-athletes with rotator cuff related shoulder pain. So the next few slides here, we'll do that one more. So essentially this is another creation by one of the physiotherapists named Jill Cook, and this is helping explain pain in a time frame. Essentially, on the y-axis, we have pain up here, no pain down here. On the x-axis is going to be time. And she says that for anyone that comes in with shoulder pain, we want to let them know these things take time. It takes about 12 weeks. But unfortunately, patients will have the understanding that when they start treatment, every day will look like this, and every day will get better. But realistically, on the next slide, it looks like this. And there's going to be ups and downs, hills and valleys, and this is totally normal, just because we still have to continue on with the day. And there's certain things that are going to be triggering your pain, but that's where we come in and let them know these are things you can change. I like to draw this out and give to patients because, let's say scenario 1, a patient comes in and says they need treatment for the shoulder, you give them exercises, and they don't get one of these. They go home, they do the exercises, and they go about their day, and they flare up their shoulder. They come back, and now they're like, that exercise actually flared me up. And then as a clinician, especially when I was a new grad, I start to doubt myself, and I started thinking, okay, maybe it wasn't this condition I diagnosed you with, maybe it's something else. And once I started doing that, then I started changing my treatment plan, and now I've lost myself, but I've also lost the patient, right? What we need to do is get them understanding this visually, so that when they do come back and have pain, which is going to be more realistic, they understand we've got to stay the course. Stay the course, and with time and the right treatment, things will get better. And as physiotherapists, as kinesiologists, we want to set the expectation that, hey, this line here never joins that x-axis. And personally for me, I would never tell a patient, your treatment with me is going to be pain-free in X amount of time, or you're going to be living pain-free in X amount of time. I just don't think that's realistic. I think what I can promise, or we can promise, is that, hey, we can do our best if we show up every day, and we can get the best resolution of symptoms, but we're not going to get full resolution of symptoms. And as healthcare practitioners, we have to be realistic and understand the limitations that we can provide to our patients. but it's a great graph to have and keep in the back pocket, just in case you have patients that are very sensitive. It's also a great way to explain to someone who, let's say, is a smoker, so lifestyle things. And someone that comes in as a smoker might rehab or might rehabilitate a little longer than somebody who doesn't smoke, just because we know smoking can heighten our inflammation, which takes longer to recover and takes longer to rehab. But a great way to look at how do we explain timeframes with patients and understand that these things take time, and it's a lifestyle change. It's habits you've created in your day-to-day stuff that once you stop rehabbing or even just going through a routine, whether it's 2 minutes in the morning or evening, that once you get off of it, you're going to get back to pain. And getting patients to understand that knowing what to do in the morning or evening in terms of stretching can help with their pain long term. Issue number 4, unload is required. So this principle applies to all patients, in my opinion. If they can cope with the pain, keep going. If not, relative rest is suggested, but relative rest doesn't mean stop what you're doing and just chill and go to bed, right? Like it's more so about, okay, let's bring down the pain and what can we do to help with your pain long term. So we're thinking about the activity or the sport. We're thinking about IDF, which is intensity, duration, and frequency. These are things we want to consider when patients come in with pain, and ideally, patients are going to be managing their pain on their own. And so they're going to be doing clinical experiments from home, seeing what helps their pain. So whether it's an athlete returning to a sport, we want to reduce their training load by either a third, a half, a quarter. If it's just a weekend warrior or your average Joe, what can we do in terms of activity modification and reducing load? But the idea here is, can we bring the pain down to a certain level so we can keep them in the game? So whether it's the game itself or day-to-day stuff, keep the pain down low enough, 2, 3 out of 10, and then allow them to be not so flared up so they can actually rehab their shoulder pain. Okay. But typically for issue number 4, even with patients coming in and they say, this is what they have, and then you tell them, hey, it's gonna take this long. And they'll come back and say, like, I gotta get back in the game, I got a game coming this week, or I got this competition or race coming up, or I have to take care of the kids or go to work. I typically give them the analogy that, well, if I had a patient come in and they had a fracture versus someone that had a muscle tendon problem, if I had a choice to treat one patient, I'm taking the fracture, because patients make the compromise. If you have a fracture, you're not going to walk or run full weight bearing. You're not going to participate in the activity, and you're going to start modifying things right away because you understand this bone needs to heal. And if someone can actually take the same amount of respect that they have for a fracture and put it on a muscle tendon, then that's where we'll start seeing changes. So giving them that analogy, from my perspective, kind of just reframes how the shoulder pain can work. So if they can just give themselves 2 to 4 weeks of just modifying duties and changing load, like they'll see that become fruitful later on versus trying to power through it. Issue number 5, appropriate rehabilitation progression. This is where I believe we build, and this is where I think you guys shine most, right? And for me, for any patient, whether it's Usain Bolt or just an average Joe coming through the clinic, the goal is, how can we take our patient on a journey so they can exceed their expectation? Because by end of it, I mean, I think patients should be able to say, I couldn't believe I was able to achieve this, or I couldn't believe we were able to accomplish this, or I accomplished this. And I think this is where true impact lies as clinicians, right? If we're able to help with their pain, but also create some sort of change in lifestyle, and they've created a new habit and a new routine, and that they stick with for the rest of their lives, I think that's where most of the impact lies for all of us. But yeah, Keith will dive into now a little more of how the exercise progression works, or what we think works.
So on the next slide, so with the exercises, like Brian says, you guys are the experts with the exercises and progression of exercises. We just wanted to talk about a couple of points that we see is missed a lot of the time. One being you cannot isolate specific rotator cuff muscles. Like no matter what they tell you, trying to isolate the supraspinatus, you're not going to be able to do it in isolation. They all work kind of together. So what we want to do is you don't want to miss those large compound exercises. Even things like push-ups. You know, a lot of clinicians, physiotherapy and kinesiology, a lot of people will do your classic external rotation down here. You're trying to isolate specific muscles. You're trying to make things very basic, and that's good. Like that's definitely needed, especially early on, especially if they're very in a lot of acute pain. But as they progress, you want to try to don't forget those large compound things. So overhead pressing, even push-ups, things that can work that shoulder girdle together is really, really important. And then that takes us to the next couple things here is you don't want to also forget overhead exercises. I think that one of the biggest problems as clinicians, what we tend to do is we tend to stop the program too early, right? We'll get them out of pain, and or maybe they'll have a little bit less pain, and then we kind of finish off there, and we want to progress them out to do their own thing on their own and make sure that they are able to maintain it on their own. But one thing that we don't want to forget is, adding in the harder things, adding in specific things. At the bottom there, specificity is really, really important. So no matter if they are the athlete or they're someone who's just the average Joe weekend warrior who doesn't have a lot of sport requirements, you still need to do things like overhead exercises because you still need to lift things into the cupboard. You need to reach things from the cupboard. Even if someone, he's not a sporting person at all, but let's say they're a painter, right? They're climbing a ladder and they're painting a roof, and their arms out here, they're doing a lot of this motion all day, right? If they come in with shoulder pain, and you train them up here like this, and maybe even like up here a little bit, and their pain goes away, you're good to go back and do whatever you need to be doing. They'll go and they'll pain, and maybe after a couple of weeks, if they do this motion a lot, then that pain can still come back, and then they'll come back to you, and then it's a cycle all over again. Whether if that happens, you can just nip that right in the bud by completing their rehab. What I like to tell my patients is when they're pain-free, obviously we start to wean off of the exercise the treatments, but I still give them things to work on, right? Whether or not they go and do that for a month and then they come back to see how, just as a checkup, see how they're doing, get some harder exercises, because I always harp at them, look, when you're pain-free, that's great, but we need to still continue to train. And that goes in with what Brian said, it's a lifestyle change, right? A lot of times I tell them, you don't need to go to the gym, you don't need to become a weight junkie, but you want to still be doing some form of exercise throughout your life because it's just that beneficial for you. So with the overhead exercises, things like simple face pulls, overhead press, like I mentioned earlier, you can do like shoulder windmills, even just 90-90 in these positions here. And then when you train in those positions, you also want to add some external forces, like that painter up here. This is a stability component here, right? You want to try to test them by using other bands, by using perturbations, different weights and that kind of stuff to really get them to stabilize their shoulder, but also you're training and increasing that strength. And then obviously if you have a higher level athlete or you have people who just have higher requirements, they want to get back or they have goals of doing some sports like tennis players, for instance, that kind of stuff. You want to work on the stability, plyometrics, speed, and power. A lot of people also underestimate the amount of strength gains you can get from power training, from just switching up the speed a little bit can really work on increasing their strength in a way that they're not used to, right? So it's like now it becomes a different stimulus that they're not used to. It becomes more fun too, let's be honest. A lot of times rehab can be boring for a lot of people. So doing those type of things can switch it up, make it different for them, and then again, gets them to buy in a little bit more. And by that point in their rehab too, they should be doing things that are a little bit more challenging. So just a couple of things not to forget when you're completing your rehab program.
And this is just an illustration of how complex our shoulder can be and the amazing and beautiful things our shoulders are capable of. But when it comes to rehabilitation, it can be simple. We can just consolidate the information and find out what we can do to get them back to what they're doing before. Next slide kind of just shows little things such as very, very low intense training or rehab for the shoulder, very stabilized and safe environments, but things that Keith was alluding to, overhead stuff is great things and great ways to challenge the shoulder to get them back to doing what they're doing. So hopefully, I'm sure most of this stuff was a refresher or things you already know, but I believe that consolidation is the best form of education sometimes, and just relearning things and hopefully getting a different spin on things helps add to what you currently know in your current bag. Major takeaways, like the cup analogy. I think just changing the way we see pain is going to be helpful in explaining and getting patients to buy in on their rehab. And timeframes, that graph that we talked about, I think that's a great tool to have in the back of our bag just to hand out to patients that are coming in with shoulder pain for the first time.
Yeah, with the assessment that I alluded to earlier, a very quick assessment. I just wanted to get you guys to think about it. Like, it doesn't need to be super specific and it doesn't need to be super detailed, right? Simple stuff, and you can pick up a lot of things with just range of motion, isometric strength testing. And so when you do those assessments, make sure you're always, thinking about what the patient's telling you. Look at their face, take those small things out of it, and look at the quality of the movement and that kind of stuff. A lot of the times, myself included, sometimes when you go through an assessment, you're just going through the movements, right? You're doing it because you know you have to do it, but really sometimes you need to think about it a little bit more, talk to them while you're doing it, and by keeping it simple, it's an easy way to do that. And then psychosocial factors, all those factors we mentioned, we need to start incorporating that into our treatment a little bit more. Take those little things that they tell you and really put it in the back of your mind so you can bring it up later, right? A lot of the times people neglect that, and in our industry, things are moving all the time. So now we know how important they are. We just need to put into action a little bit more. And the last thing here is the progression of exercises. Like I said, this is your field. We want to make sure that we just don't miss certain things, right? Complete the program, add in those overhead exercises, add in those different types of stimulus and strength exercises.
Absolutely, and it's just a way to push our patients. I think all this applies to a full treatment, and this here for me is probably what stands out most, just so we can get patients to get on the same page as us. An analogy I like to use for time frames is that when it comes to shoulder pain, it's analogous to someone that comes in with high blood pressure. And for someone to come in with high blood pressure and expect to leave without high blood pressure in one treatment, it's probably unrealistic, and I hate to believe that. Same thing with diabetes. For someone that comes in with high blood sugars, to leave within one session to have no high blood sugars, unrealistic. Asthma, same thing. So any persistent health condition takes time, and you got to get to know the patient, and they have to go through a routine, a lifestyle change to see these changes actually come to fruition. Same thing with pain and shoulder. And if we can have that mindset, hopefully understanding why we need to be together for about up to 12 weeks, maybe a little longer, is going to be more manageable and makes more sense to the patient as well. So.
And these are just some references you can take a look at. We put some in there, not all of them. There's a bit more, but.
So thanks for your time, guys. I appreciate it. And yeah.
You guys have any questions? Any questions at all?
So yeah, like in terms of the cup analogy, right? Like increasing the size of the cup. Right, so like, how do you
do that, right?
Yeah, more specific. So that, like, obviously, like, what we can do as physiologists is, like, give them exercises, like, empower them to be able to, like, lead a more active lifestyle and whatnot. But again, like you said, I mean, chronic pain is so much more complex than that, right? It's so like psychological as well. But in that sense, like when I'm dealing with patients, I almost feel like powerless in that sense. Like, how can I do to help them?
Absolutely.
I guess apart from directing them towards, taking advantage of clinical counseling and all that.
Exactly, and that's the one of the first things we want to do. That we want to do is get them out and sourcing them to the right counselor. To build a bigger cup or have the larger capacity over time is, yes, what we do first and foremost is rehabilitation and exercises, and just getting them stronger is going to help with that. But as kinesiologists, as physiotherapists, our first line of treatment isn't to counsel them, but I think through education and like our lifestyle experiences, and if we can get that across and educate that to them to either live a different lifestyle or add something that's more beneficial to their lifestyle, can create more habits is what we're trying to do. Because I think motivation to do exercises is one thing, but getting and providing motivation to create a change, right? Like, yes, I'm doing external rotation, but external rotation is allowing me to take care of my kid. Like attaching the why, essentially, right? Like just getting patients to do, here's your 3x10, here's your 6 exercises. That to me is not meaningful, right? To me, I'm taking that and I'm putting that into, okay, so here's your exercises, here's what you do, or here's what's meaningful to you. And if it's hiking or taking care of your kids, going on vacation, or work, I'm taking those exercises and I'm putting that in there. Like now you've attached your why. So at least on those days that you don't want to do it, you'll do it because you'll remember your why. So to me, it's treating physical and mental, and your mental becomes bigger, your cup becomes bigger. Yeah. Does that make sense?
Yeah. As you keep talking to them and just keep treating them, every time you're obviously educating them, and every time you educate them, when they build those lifestyle changes and they build those habits and just understanding their body a little bit more, then their cup expands a little bit more. Then they're able to handle a little bit more. As you start to talk to them and they understand these stressors, they understand not to overdo it, then not necessarily the cup expands, but those other factors start to shrink, right? So then they're able to go through their life a little bit better, and in a way that's, okay, now I know where my cup size is or what stressors are going into it. I'm not going to overflow it. So it's not just increasing the size of the cup, it's also decreasing those stress factors on the side. And like, I understand what you're saying. You can feel very powerless. Yeah. I work in a clinic where it's just, I deal with ICBC concussions all day, and there's like 10 to 12 people that come in and they're all there for 2 years. That's also a different side of things, but that's the reason why I harp on the psychosocial factors a lot, is because they come in and they're all depressed, they all have anxiety, which is for good reason. Like imagine one small rear ender and it's completely affecting the course of your life, right? And they come in very powerless, it makes you feel kind of powerless, but what I've learned over the last 2 years working with these patients is that if you just listen to them and you give them those small things every session and keep that positivity. A lot of these patients, like you said, the ICBC patients that you feel very powerless with, if you keep that positivity and you show them that these small improvements are happening and these small progressions are happening, they will start to change their mindset. It's not going to be easy, right? It's not going to be quick either. It takes a lot of time, but you as a clinician can't give up either, because if you give up and they sense that, then you're all fucked, right? You need to make sure you keep that positivity. And I tell my patients all the time, like for these patients, they come in, they don't get better for like 3, 4, 5 weeks at a time. And then when they do get better, it's literally one thing. Like they go from, I can now wash my hair. Like those little things I hone in on that a lot. I'm like, look, this is an improvement. I already told you from the beginning, this is going to take a while. And for that specifically, when they come through the doors, I tell them, look, you're here, and a lot of patients here already are going to be dealing with these injuries or these symptoms for at least a year, right? That's just the nature of our clinic, and that's just the nature of when you get sent to see us, right? So they understand that, I tell them that, and then a lot of times I don't really do too much for them in terms of treatment. I give them exercises, I do a little bit hands-on stuff, but it's the everyday things that really they take away from that. And they come in, they feel like they're heard. A lot of the times the patients will come in, they'll be like, I leave here with, I feel better because you're actually listening to me. I feel better because I know how to sort of deal with kind of these flare-ups and that kind of stuff, which they don't get everywhere else. So you want to kind of be that person to do that for them.
It's a big question, and it requires probably a big answer, but I think as physiotherapists, as kinesiologists, like that's our first line of treatment. That's what we went to school for. But through more recently in my practice, like we treat more than physical, we treat mental too, and I believe that like Brian the physiotherapist is what you came to see, right? Or who you came to see. But I think realizing that I'm Brian, not just a physiotherapist too. You're not just a kinesiologist, you're still human beings, and there's life experiences that you guys have gone through. And if you can impart something in your life that you found very valuable, that you found that was a game changer or changed the course of your life, and you've continued on with that, that's something that somebody can use as well. right? So it's not just here's exercises, here's an interaction that you can build with someone, and I think of it like that when I help patients too. So, but doing little things like that can, in my opinion, I think can build a bigger cup, right? Reframe their way of thinking, get away from what has caused their pain, and change their course of thinking, and like Keith said, like be positive. Obviously, it's hard to be positive all the time, but when you do it consistently rather than every day, just do it consistently. Because some days you're not going to feel it, right? Yeah. And that happens, especially when you treat them for like 12 weeks, right? So you know the drill. Yeah. So yeah.
Any other questions?
When you're like simplifying like the mechanical shoulder pain, like stiff, weak, unstable, do you guys use any other tests besides like your table apprehension test to like test instability, like functionally? It says you test right now, strength, range, so you cover the 2 boxes. Is there one more?
So usually, sorry, like you're talking about tests specifically?
Yeah, or like what do you guys do to like assess like stability of the shoulder besides like your apprehension tests and things like that?
Right. So yeah. So the first thing is I'll do their apprehension test. I'll get them laying on the table. You know, I also like to see how they just deal with being up in here. Right. They're not specific tests, but what I can get them to do is I get them to hold their arm out, even holding a little bit of weight. I'll see when they start to fatigue, and then I'll even add like some of the exercises. I'll add in a little bit of perturbation, get them to hold it there, and you can tell really easy they lose that strength, or a lot of the times for instability, you need to take away from what they tell you, right? So it's a lot of history taking. That's obviously something we didn't go over, but history taking is very important. And when they tell you things like, oh, sometimes I like I go to reach for the cup, like a cup out of the cupboard, and I just feel like there's something off with my shoulder. When you and I do this, like this is fine, right? Oh, well, this side, I've dislocated this shoulder, so I can understand that. But like even just things like lifting, and if they start to do this, like they're shaking. I see patients come in sometimes they don't even know that they have an unstable shoulder, but they'll tell me, or I'm getting them to do an exercise and they're doing it, and then they go up to here and they're like, oh, like I'm starting to shake, and they're like, is this normal? I'm like, not really, no. So those are the things that you can take away. Like I said earlier, those special tests aren't really that special. They're not really that specific. So it's a combination of seeing what they do with the range of motion, what they do with the strength testing, and then their history as well. Like apprehension is really good, but that's only one thing. You can do it here, you can do it straight arm like that, like a little bit of a different angles, and that's all that I do, and that's enough to kind of be like, okay, this shoulder is a little bit unstable, let's work on that a little bit as well. Yeah. Cool. Anything else? We're all good? Awesome. Thanks guys.
Appreciate it.